Good afternoon. I will now call this meeting of the National EMS Advisory Council to order. Thank you, representatives, for joining us for the third round of the meetings in 2023 session of NEMSAC. This is the first live in-person meeting we've had since January of 2020. My name is Brendan Hayden, and I am the Health Administrator Sector Representative, and I'm honored to serve as the NEMSAC Chair and Moderator today. For those members of the public joining us virtually today, we'd like to extend the warmest of welcomes. One of NEMSAC's lessons learned during the pandemic was the Council had more public involvement when the meeting went virtual. To promote continued public involvement, we've decided to hybridize the NEMSAC meetings so that we may resume live meetings in Washington, but also invite the public to join us in a virtual space. Per usual, our meetings will proceed following the agenda. Representatives, please always remember this is a public meeting, and to please hold your questions and comments until the floor is open for discussion and/or the chair recognizes you. At the designated time on the agenda, the floor will be open for questions or statements from the public during the public comment period. In the event we are addressing an item of business when the public comment period is upon us, I will ask for that discussion to pause so that we can observe the public comment period as was published in the agenda. Now let us begin with our first order of business, the introduction of the NEMSAC representatives and the disclosures of conflicts of interest. The chair would like to recognize Mr. Gam Wijatonga, Director of NHTSA's Office of EMS. Gam?
Thank you, Mr. Chairman. Appreciate it. On behalf of the NHTSA Office of Emergency Medical Services and our partners on the Federal Interagency Committee on EMS, I would like to extend a welcome to all the NEMSAC representatives in the room and online, as well as members of the public that have called in for our third meeting of calendar 23. For those representatives who are joining via Zoom, again, I'd like to extend a welcome to you and the public. And I think I can speak for the NEMSAC in saying that your input to the deliberations is most welcome and valued. Please be sure to send your comments and/or questions in using the live chat feature so we can hear what you have to say during our time of public comment. Public comment must be received no later than 5 minutes prior to the public comment period so that we can read aloud during the meeting. So representatives, at this time, I'll state the name of each sector. And after I call out the name of your sector, please unmute or activate your microphone, introduce yourself by name, where you are from, and then please declare any conflicts of interest you may have. So, kicking it off, hospital-based EMS.
Paul Brennan, Lowell, Massachusetts, no conflicts.
Tribal EMS.
Danita Kohler, Alaska, no conflicts.
Local EMS directors or administrators.
Lisa Basgall, Houston, Texas, no conflicts.
Trauma surgeons.
Mark Estring, Rochester, New York, no conflicts.
EMS data managers.
Tom Arkins, Indianapolis, Indiana, no conflicts.
EMS researchers.
Jason McMullen, Cincinnati, Ohio, no conflicts.
Hospital administrators.
Brendan Hayden, Portsmouth, Rhode Island, no conflicts.
Public health.
Carol Jorgensen, Nebraska, no conflicts.
EMS practitioners.
David Pfeiffer, Stanton, Kentucky, no conflicts.
Legislators.
Sue Prentice, Lebanon, New Hampshire, no conflicts.
Consumers.
Io Ogunsola, State of New Jersey, no conflict of interest to declare.
Educators.
Daniel Gerard, San Francisco, California, no conflicts.
Quality improvement.
Mike Tegman, Santa Barbara, California. I am employed by First Watch, which is a potential conflict.
Volunteers.
Wade Miles, Canton, Georgia. No conflicts.
State EMS directors.
Justin Smith.
Justin Romanello, Hollis, New Hampshire, and no conflicts.
Air Medical.
Yvonne Byers, Spokane, Washington, no conflicts.
Medical Directors.
Brandon Morchetti, Hot Springs, Arkansas, no conflicts.
Emergency Physicians.
Kendall McKenzie, Ridgeland, Mississippi, no conflicts.
Pediatric Emergency Physicians.
Sylvia Usuanta, Pittsburgh, Pennsylvania, no conflicts.
Public Safety Answering Point Call Takers, Dispatchers, 911. Okay. Emergency Nurses.
Tabitha Vaughn, Indianapolis, Indiana, no conflicts.
Emergency Management.
Frank Quintero, Westchester, New York, no conflicts.
State Highway Safety.
Bradley Esgen is from Woodbury, Minnesota. However, he has to respond to emergency. He'll be back with us as soon as possible. He asked me to let you know he had no conflicts of interest.
Thank you, Clary. Thank you, everyone, for your introductions and your disclosures. You may have noticed that we only introduced 23 of the 25 NEMSAC sectors of EMS. To fill the fire-based EMS and private EMS sector vacancies, applications were solicited and collected through April 13th of this year. In May, the NEMSAC selection panel forwarded names of nominees for the candidacy of appointment to the Office of the Secretary of Transportation for vetting and background checks. Once the Office of the Secretary's staff responsible for vetting have performed their duties, 2 suitable candidates will be forwarded to the Secretary of Transportation for official appointment. When the appointments have been sent, received, and confirmed, they will serve, and we will make a public announcement about the appointees. We hope to be able to make the announcement of our 2 new appointees in November. And that's it for me, Mr. Chairman.
Thank you, Gam. Thank you, Gam. Appreciate that. Representatives, you should have had time to review a digital copy of the summary of the last NEMSAC meeting. Post that review, are there any corrections or amendments to the record? Hearing none, all those in favor of approving the record, please unmute and say aye. Those that are opposed, unmute and say nay.
Aye.
Any nays? Any abstentions? The motion passes. Moving on, FICEMS update. As you may know, FICEMS is not required to provide NEMSAC with an update of its activities. However, I and the NHTSA Office of EMS felt it would be good to keep the lines of communication open between FICEMS and NEMSAC, as NEMSAC regularly makes recommendations to FICEMS. Therefore, we have extended an open invitation to the chair of FICEMS to come by and provide an update, so we may remain abreast of exactly what's happening within FICEMS, our federal partners. So, to that end, I would welcome Mr. Nanda Siravasan. I'm glad you were able to join us today to provide an update. I would like to yield now and allow Nanda to give us an update from FICEMS.
Thank you, Chairperson, for the invitation to join the council meeting today. FICEMS, as you all know, was established in 2005 to ensure coordination among federal agencies supporting local, regional, state, tribal, and territorial EMS and 911 systems. FICEMS was also established to improve delivery of EMS throughout the nation. On June 28th this year, FICEMS hosted a general meeting. I'm going to give you a brief rundown of what was discussed. From the Department of Health and Human Services Administration, HRSA EMS for Children recently partnered with NHTSA OEMS to create a NEMSIS-based pediatric readiness dashboard for national and state level quality improvement efforts. This dashboard was just released today. In fact, I just saw some positive press releases coming out. So congratulations to HRSA and NHTSA OEMS. Assistant Secretary for Preparedness and Response for EMS is looking for additional staff. The job listing is posted on usajobs.gov page. Encourage everyone to look into that. The Counter Narcotics and Counterterrorism Medical Support Quantums course provides EMS tactical training for those who support law enforcement operations across the country. In May 143 graduated from the basic quantum scores hosted in New York. The Centers for Medicare and Medicaid Services continues to evaluate flexibilities in waivers and models used to prevent difficulties in obtaining payment during COVID. They have been very engaged in emergency triage, treat, and transport model, the ET3 model. CMS Innovation Center has decided to terminate the program on December 31st, 2023, and a notice of termination was sent to all model participants in July 25th, 2023. Additional details are available by searching ET3 on cms.gov. The Office of Health Security within the Department of Homeland Security has been focusing on 3 critical areas in the last 3 months. One is a mechanism allowing DHS EMS practitioners to have portability of medical credential to practice across borders. Second, patient care reporting system platforms. And third, clinical immersion and special skills training. U.S. Fire Administration reorganized at the end of 2022. The FICEMS representative is now leading the National Fire and EMS Division. USFA is in the process of conducting an EMS programs needs assessment that will lead to recommendations to effectively address changing needs and future of EMS. They're also involved in several projects. Some of them were outlined as EMS burden of care, addressing diversity, equity, and inclusion in the field, and response to electric vehicle incidents and to civil unrest. USFA is also developing programs, handbooks, guides, and manuals. The handbook for EMS medical directors and retention and recruitment for volunteer emergency services manuals are the most recent publications that we're citing. NHTSA, Secretary Pete, released the National Roadway Safety Strategy. As you all know, a year ago, it has been the focus of DOT's efforts. The NRSS outlines the department's comprehensive approach to significantly reducing serious injuries and deaths on our nation's highways, roads, and streets, of which EMS is such an important part of the post-crash care element of the system. NRSS represents the first step towards an ambitious long-term goal to reaching zero roadway fatalities. The DOT is also helping to ensure that the Federal Highway Administration funded programs, the NHTSA funded programs, and State Highway Office partners who fund recipients are focused on achieving the same goals. The aim of the safe system approach is to have safer people, safer vehicles, safer speeds, safer roads, and most importantly, the post-crash care element for us in NEMSAC. DOT has 3 key actions related to post-crash care. 1, improve the delivery of EMS throughout the nation. 2, improve the availability and quality of national EMS data. Improve EMS personnel on-scene safety through outreach and training. The Bipartisan Infrastructure Law established a new program called the Safe Streets and Roads for All, SS4A grant, with about $5 billion in appropriated over 5 years. Grants can fund regional, local, and tribal, but not state initiatives to prevent roadway deaths and serious injuries. The SS4A grant for last year came to a close on July 10, 2023. The SS4A grants that are not spent from last year are being carried over to the next year. So please stay tuned for more opportunities to apply. I know that this is one opportunity where state EMS can partner with state government agencies, state local agencies in order to compete for these grants, and you stand a very good chance. NHTSA and its regional offices are also partnering with each state highway safety office to offer to the tune of $850 million in state and community grants for improving state highway traffic safety information systems, racial profiling data collection, occupant protection, motorcyclist safety, non-motorized vehicle safety, driver or office safety, as well as having programs centered around preventing impaired driving and distracted driving, roadside deaths, and speeding reduction. So whole set of things are being worked on, many of which have a lot of applicability to the work you do. In January 2019, NHTSA published the EMS Agenda 2050, a people-centered vision for future of EMS, Agenda 2050. This collaborative project set a vision for a people-centered EMS system that serves every individual in every community across the nation. Later this year, NHTSA and our partners will begin a new project to develop EMS Education Agenda for 2050. This project will build upon achievements of EMS Education Agenda for the future, systems approach to lead a national conversation around the future vision for EMS education and EMS as a profession. So a lot of activities there at DOT. The Federal Communications Commission is active in ongoing initiatives to improve technical capability of the nation's 911 system and has taken 2 recent actions. The first one is that in December 2022, FCC issued a notice of proposed rulemaking regarding location-based routing for 911, an emerging technology that identifies the location of the handset rather than the location of the cellular tower that handles the call. This new system will reduce the number of calls that are required to rerouting from one 911 center to another by 20 million and allow for more rapid dispatch of response teams. The FCC has proposed a timeline to require all cellular providers to use this technology and is currently receiving comments and feedback. They expect to take further action in 2023. In July 2023, a second notice of proposed rulemaking, which proposed requirements for the delivery of the next generation 911 NG 911 system calls, was published. These rules would authorize multiple new capabilities, including the ability to text 911 and to transmit data, video, and images. In order for the transition to be fully realized, the wireless and wired carriers will need to adopt new internet protocol-based formats and emergency operation plans for 911 calls that originate in their networks. That's the end of my update, and thank you again, Chair, for giving us the opportunity to provide that update from FICEMS to this FACA committee. Thank you.
Thank you, Mr. Srinivasan. Very much appreciate your time today and the work that you're doing at FICEMS. For the representatives also, there is bidirectional communications with FICEMS. I do provide an update to FICEMS as well at their periodic meetings, so they do get updated on the active advisories that we're working on, things that are in development as well. So thank you again. Next up, the Chair recognizes Gamwa Jatanga again, the Director of the NHTSA Office of EMS, to provide an update on the National Roadway Safety Strategy Post-Crash Care Initiative and Actions. Gam?
Thank you again, Mr. Chairman. So as Associate Minister Srinivasan mentioned, DOT continues to work with our partners on implementing the National Roadway Safety Strategy and our nationwide effort to eliminate crash fatalities and injuries. And I want to thank the National EMS Advisory Council for your advisory to NHTSA on how to improve post-crash care. We've shared your advisory widely with the community. It's posted on ems.gov, and we know a lot of folks have been looking at it. So as you know, post-crash care under the NRSS is focused on improved scene safety and patient outcomes as well. And we have a fair amount of activities going on in that realm. And I'll pause for a minute and just see if we can pull up the infographic. And Clary's working on it. Great. And if you could make that just a little bit bigger, Clary, it'd be great. So this is hot off the digital presses. On Monday, our NHTSA's acting administrator, Ann Carlson, finalized this infographic on post-crash care. It is, we are working on putting it up on ems.gov as we speak. So that will probably be done before the end of the week. And I'll just talk about it briefly. Really, the purpose of this infographic is to stimulate, be a guide and stimulate a conversation between highway safety officials and EMS and 911 officials. It's a conversation starter because based on what we heard from your advisory in the NEMSAC, that conversation and that relationship building is really the critical step in improving post-crash care. So we highlighted some data sources that could be a resource for highway safety, EMS, and 911 in having that conversation. First, speaking to problem identification, we know through the National EMS Information System, or NEMSIS, that in 2022, 911 dispatched EMS to approximately 1.5 million crashes. And of those crashes, of the fatal crashes that occurred, 40% of those fatalities were still alive when EMS arrived on the scene, but then died within 30 days post-crash. And that's out of the total in 2021 of nearly 43,000 fatalities in the United States. If you could scroll down just a little bit, Clary. We also noted in looking at 2022 NEMSIS data that there were 8,747 events where EMS responded to crashes involving an ejection of the patient. And as you know, under field trauma triage criteria, that requires transport to a trauma center. Additionally, interestingly, we at the national level, we don't report data on extrication incidents, but the National Fire Incident Reporting System, or NFIRS, which is at the U.S. Fire Administration, does collect that data. So we did work with Rick Patrick and his folks on pulling out some NFIRS data, and there were just shy of 49,000 reported incidents involving vehicle extrication. Again, another criteria for transport to a trauma center. And I would note with NFIRS, as they've reported, this is not a complete count of all the incidents in the United States, so it's likely higher. And then finally, again, using 2022 NEMSIS data, we know that there were nearly 170,000 events where EMS responded to seriously injured crash patients. Again, folks that would easily meet criteria for transport to a trauma center. So we feel this data is a good way to kind of talk about the scale of the post-crash care challenge. And I think we're fairly confident saying that at the state and local level, the EMS data is much richer and can lead to many more conversations. And finally, under countermeasures, so we chose to highlight some of the things that the NEMSAC's advisory talked about when you issued your recommendations to us. This is not complete or exhaustive, and I would just, of course, say that at the state and local level, the challenges and the capabilities obviously vary. But these are just some highlights we chose to hit. One, the importance of emergency medical dispatch and EMD protocols by 911. We know, based on our national estimates, that actually less than 50% of the PSAPs in the United States use some form of EMD, and this is obviously a first critical link in the care that are provided to crash patients. Number two, the importance of timely on-scene care for critically injured patients. That we know that the care that are provided to seriously injured patients has a big impact on their ultimate outcome. Number three, transportation to a trauma center using field trauma triage guidelines. Again, the importance of transporting injured patients to an appropriate trauma center. And then finally, performance measurement that is driven by data and linked and data-driven care is really, again, a critical piece in improving patient crash outcomes. And I'll just hit a highlight because I got an email about 5 minutes ago that the District of Columbia actually just became the 23rd state to begin submitting NEMSIS 3.5 data to the National EMS repository in Utah. That was about 30 minutes ago. So congratulations to them. NEMSIS 3.5, I think, as folks know, it gives us near real-time data at the national level, and certainly at the state and local level even faster, and it really expands capabilities, particularly for performance measurements. So I get excited every time I see those notifications. Finally, under highway safety planning, if you could scroll down just a bit, Clary. Thank you, sir. This really gets to the heart of the importance of cross-sector collaboration, the safe system approach. We think there's enormous potential in involving EMS and 911 in collaborative relationships with highway safety. The data is very powerful, the on-scene care is powerful, and the ability to provide expedient care to injured patients, we feel can really make a significant difference. So again, this work, I think, reflects part of our communications to the public based on the NEMSAC's advisory. So I want to, again, thank you for that. We're doing additional activities in the National Roadway Safety Strategy. I think, as you all know, last time you heard from the Federal Highway Administration about traffic incident management. Dave Bryson in my shop continues to work closely with the Federal Highway Administration on getting the word out to the EMS community about traffic incident management and how important that is to not only mitigating these crash scenes, but keeping our clinicians safe on the roadway. Additionally, and I want to welcome the Director of the National Fire and EMS Programs at USFA, Rick Patrick, who's in the audience. We've been collaborating closely with USFA on struck-by research. We lose far too many law enforcement, EMS, fire, and towing personnel to struck-by incidents. So again, with Dave Bryson in my shop is leading new work with USFA to see how we can better address and ultimately eliminate those struck-by incidents. And then finally, related to that, I just want to mention that Dave Bryson and myself attended the National EMS Memorial Service just last month, where there were 59 honorees. Many of them fell victim to COVID, but also ambulance crashes and struck-by incidents. And certainly for me, and I think everyone there, it was just a reminder of how important our work is and how far we need to go in improving scene safety. Earlier, actually again, hot off the presses, on Monday, NHTSA published a report reviewing fatal and serious injury ambulance crashes from 2012 through 2018. This is actually, the report is now live online, and it really, NHTSA's special crash investigations over that 6-year period sent investigative teams to just about every fatal ambulance crash in the country where a clinician was killed. There's several key findings in that report, but I would focus on, for now, I would just reiterate one, which is pretty consistently across the board, our investigators found a lack of proper restraint use by clinicians and patients. And this is clearly something that we have to make progress on, because restraint use really makes the difference between survival and non-survival. So we'll be sure to share that report with the NEMSAC, but just again, for folks listening, just want to emphasize really the importance of getting our providers to use proper restraints. So that concludes my update on the National Roadway Safety Strategy and Post-Crash Care. Mr. Chairman, happy to entertain any questions.
Any questions for Mr. Wichatonga?
Thank you.
Hearing none, thank you very much. Appreciate the excellent update and the late-breaking news as well, so thank you. We're now at the point of the agenda where we're going to hear from our standing subcommittee meetings, subcommittee representatives. Just as an update, there are 6 standing subcommittees within NEMSAC and 1 ad hoc committee that's currently in place. So I'm going to ask that each of the subcommittee chairs give us an update. After each report, from the chair, I'll ask for the council if there's any questions. One thing I would like the members who are giving the updates to highlight at what stage each of their advisories are in, either the research phase, the draft phase, or the interim phase. So I'd like to start with the Adaptability and Innovation Subcommittee. Mr. Pfeiffer.
Yeah, thank you, Mr. Chair. If it's okay, I'll take these a little bit out of order from how they're listed on the agenda and begin with the body cameras advisory. That one is still in the research phase. We've had some good conversations this morning about it, and we'll have more tomorrow during our subcommittee breakout time, so work continues on that. The one that we're hoping for action on at this meeting tomorrow is the advisory on designation of graduate prepared paramedics as federally recognized practitioners, and we're asking the council to move that from the research phase to the draft phase. And so kind of as a review, perhaps especially for the benefit of our listening public, this advisory is ambitious, and it crafts a vision for creating a new role of EMS professional in the kind of the national EMS scheme, and that would be the paramedic practitioner. So paramedic practitioners are defined in the advisory as paramedics who have completed graduate level education with a clinical focus on prehospital paramedicine. So as part of the advisory, we're also calling or essentially proposing the establishment of the MSP, Master of Science in Paramedicine credential, as being equivalent in concept to a Master of Science in Physician Assistant Studies or Master of Science in Nursing. and further suggesting that paramedics who obtain an MSP be granted federal recognition as practitioners. So right now, that list of federally recognized practitioners essentially is physicians, physician assistants, and nurse practitioners. I think there in some of those lists, there's some other individuals like clinical psychologists and master of social work. But in general, it's individuals who have completed graduate education, which is in fact one of the criteria to become a federal practitioner. The purpose of this is several-fold. One of them is recruitment and retention. We'd like to provide a clinical ladder for paramedics to be able to progress beyond the technician level if they choose. So this advisory does not require anybody to earn a degree or become a practitioner. It simply establishes an optional pathway for individuals to follow and for agencies to employ if they choose. The second thing we're hoping to achieve is better patient-centered care. Every paramedic knows, as I think does everybody who works in an emergency department where we take our patients, that a large proportion of patients probably don't really need emergency care, and their needs can be met in other ways, but the legal framework for doing that does not exist right now for paramedics. And arguably, paramedic education as it currently exists does not well prepare paramedics to be able to do that safely in all instances. So we're hoping with the creation of practitioners, we could be able to meet patients' needs a little bit more precisely in some instances. And then the third big piece is diversified and more sustainable revenue streams for EMS agencies. So practitioners with NPI numbers who could bill for basically CPT codes for all the things that we do for our patients would provide a different kind of revenue stream for agencies that struggle with sustainability and insufficient reimbursements. And probably the most kind of classic example of this is refusals of care. Patients who do need medical care but do not wish to go to the emergency department for whatever reason. Care could still be provided to them that they probably do still need at the point of illness, and practitioners could, at least theoretically, be able to bill for those services. To achieve all of this, as I said, is pretty ambitious. We make several recommendations. The thrust of all those recommendations is basically asking the relevant entities, so CMS, HHS, potentially even Congress on some aspects of this, to go ahead and grant that status or that privilege of practitioner to paramedics who complete that kind of education. And we also call on NHTSA to convene subject matter experts who could craft the curriculum for MSP candidates and the learning objectives and so forth. And to work with the Department of Education and HRSA to allocate funding for the establishment of MSP programs. So that is the thrust of that advisory. And again, tomorrow we will be asking the council to move that from the research phase to the draft phase. We have received some public comment that we will be addressing tomorrow. Thank you.
Thank you, Mr. Pfeiffer. Are there any questions from the council members for Mr. Pfeiffer on either of the two advisories that they're working on? Oh, Jason. I'm next. You're next. Oh, I'm sorry. Okay, hearing no questions from any other members of the council, I'd like to next recognize the subcommittee chair, Dr. Jason McMullen from the Equitable Patient Care Subcommittee. Dr. McMullen?
Thank you very much. Our group continues to work on two advisories. One is a carryover from the last session, and one is new for this session. Both are still in process and do not anticipate moving either forward as part of business of this meeting. Our subcommittee meeting is tomorrow morning, which is the next one. The two that we're working on, one is the equitable access to EMS on the basis of population density. As we were working forward towards this, there was a wonderful publication that just came out called Ambulance Deserts, Addressing Geographic Disparities in the Provision of Ambulance Services. This is a very well-resourced document that will directly inform some of our work. And we have invited the PI of that study, Dr. Yvonne Yonk, to present at an upcoming meeting to inform us so we can learn from their work and see where we can move forward. This second advisory that, again, one that we have started this year is addressing mitigating medication supply and device shortages. As I'm sure many people know, recent Pfizer plant was taken out by a tornado and was the sole source of many medications, and we are still waiting to see what impact that will have. We have invited subject matter experts to this month's regularly scheduled meeting, as well as to the following meeting. These are representatives from the National Association of EMS Physicians, who have been working on this for many years, as well as a representative from the Food and Drug Administration to learn more about what they are already doing and what the future may hold. We look forward to having substantial updates in time for the November meeting, especially on the shortages advisory.
Thank you, Dr. McMullen. Council members, are there any questions for Dr. McMullen or the subcommittee? Hearing none. Next subcommittee is the Preparedness and Education Subcommittee. Ms. Lisa Baskell, who sits as the subcommittee chair. Lisa?
Thank you, Mr. Chairman. Our committee has 3 advisories on the table at this point. One of them, ensuring optimal emergency response to a fully integrated 911 and emergency medical dispatch system, is currently in interim status, and we are bringing it to the full council tomorrow to vote to hopefully move this to final status. This is a advisory that the previous committee worked on for the last couple of years, and we hope we'll be able to, move this one to final tomorrow. We have 2 advisories currently in research status. One is establishing best practices for EMS to prepare for planned and unplanned large-scale events. In our last meeting, we were fortunate to hear from a subject matter expert, Chief Andrew Bowes, the EMS Chief of Planning and Special Events from Indianapolis, with his input on this topic. We have another subject matter expert scheduled. Chief Michael Fields from the FDNY will be speaking at our next monthly meeting in August, so we can continue to get advice from experts in the field on these topics of large-scale event planning, particularly for pre-planned events. The other advisory that the committee has started to research is EMS response to active threats. This definitely is a topic that is timely. We need to do more research and get more information on this topic so that we can focus the direction that we'd like to take this to. I'd like to, my hope is that in the next meeting in November, we would be able to move the large-scale events advisory from research into draft. And then we'll see how far along we get with EMS responses to active threats, if that's ready to move to draft as well. But hopefully the committee will continue to work. But we're looking forward to hearing from more experts on these topics and making the advisories more focused.
Thank you, Lisa. Any questions from the committee members for Ms. Baskell? Hearing none, next committee is the Professional Safety Committee, which is chaired by Carol Jorgensen. Carol?
Thank you, Mr. Chairman. We have 2 advisories that are both in the research phase. The first one is crash scene safety for EMS responders and others on scene. We are specifically looking at struck by fatalities, so that ties in with everything we have just been hearing about the NRSS and the safe system approach. Also with the objectives of that safe system approach is post-crash care, and with those recommendations that NEMSAC had given back to your office, we would like to tie into that and just really focus on the struck by fatalities and any specific recommendations that we can put forth from that. Some of those things that we would be focusing on from the research that we have been doing is looking at the data or the incomplete data. We know that the Emergency Responder Safety Institute has been doing a great job in collecting data, but that is also limited to resources and to reporting that is done voluntarily. Other things that we will be looking at is the emphasis on the TIM training, trying to figure out how to get that in more places and more training. Dealing with single EMS responses with limited personnel and apparatus, EMS services that are responding on scene before anybody else is there for blocking purposes. Technology that might be recommended from past research that they've done with emergency lighting and synchronized lighting, SOGs, advancements to any of the warning devices, signage, mapping devices, such as when emergency lights are turned on scene, it sends a message on the mapping devices to those that are near the scene, alerting them of potential hazards ahead, protective gear, public education, legislation for move-over laws where there are none. Those are some of the topics that we have discussed in research, and we will continue moving forward with that. And again, this also ties in with what NEMSAC had already submitted with the recommendations in that letter of things to look at, but we really are focusing on the post-crash care for the struck by fatalities. Then we have a second advisory that we were researching, and that was helicopter landing zone best practices. And after discussing that, we felt that that was already well delineated and understood industry-wide. But as part of those discussions, there were references to the utilization, inappropriate utilization or overutilization of helicopter EMS transport. So it was felt that maybe that was a topic that we could suggest to the Sustainability and Efficiency Subcommittee, and maybe a proposed title change would be Sustainable Practices for Appropriate Helicopter EMS Utilization for Emergency Medical Transport. So that is something that we will be proposing possibly tomorrow. And then lastly, we are considering a future advisory topic to just begin research on, and that is violence against EMS providers data collection. So just actually collecting the data on violence to EMS providers. Thank you.
Thank you, Carol. Council, are there any questions for Carol? Hearing none. Next committee is the Sustainability and Efficiency Committee, Subcommittee chaired by Mr. Paul Brennan. Paul?
Thank you, Mr. Chair. The Sustainability and Efficiency Committee currently has two advisories. The first is related to EMS system funding. This was previously known as the Annual State of EMS System Financing. We've since changed the title of the document to be the Biennial State of EMS System Financing due to the amount of work and data collection that needs to occur during the 12-month period. We thought that we would be putting out an advisory that would be very difficult to actually complete and assess and have valuable data in a 12-month period. So we've changed that, and there have been some other minor grammatical changes, but we're looking to move this tomorrow from draft to interim status. The second advisory, strategies for mobile integrated health and community paramedicine funding and reimbursement, is in the research stages now. We have reached out to various organizations and individuals collecting data and looking at issues that the MIH community paramedicine providers are currently facing when it comes to reimbursement, whether it's government payers or commercial or other payers to be involved. So that is very early on, and we hope to move forward on that relatively soon.
Thank you, Mr. Brennan. Any questions from the council for Mr. Brennan? Hearing none. The next subcommittee is the Integration and Technology Subcommittee, which is chaired by Tom Arkins. Tom.
Thank you, Mr. Chair. So the Integration and Technology Committee, I want to thank our subcommittee members for all the work we've been doing on this. We've got 3 advisories at this time. All are currently in the research phase. The first one, Dr. Brandon Marchetti is leading on. It is discussing the bidirectional exchange of data information between hospitals and healthcare systems and EMS. So we feel this is a pretty important project to talk about. It's been talked about for 20 years. It's time to take the next step to move that forward, make sure that it's actually occurring. So it's getting the right people to the table, talking about what needs to be done. So that project is in the research phase at this time. Our second one is about a data manager certification. We're going to hopefully work with NEMSAC and NEMSAC to build a data managers course. So there will be an actual certification for EMS data managers. NFPA, I believe, is working on, or the U.S. Fire Administration, one of the two is working on the same initiative. So we're going to try and work with them to create some synergy between the two to see if we can make this basically a public safety manager. So what are all the data sources out there? How can we tie all these things together? Because we're all kind of in the same bucket of stuff. And the more we can collaborate with that pieces of data, knowing where those data pieces live, the better this project could be. So we're hoping to move that forward into draft status in not this meeting, but hopefully by the next meeting. Eric Cheney has worked with us too. He's got a good presentation on NEMSAC and what they've done with some of their stuff as well. And our final advisory that we're working on is actually Public Law 11583. It's Protecting Patient Access to Emergency Medications Act of 2017. It is finally coming to start to fruition at this point. Basically what this law is for years paramedics were not allowed to give, legally, not allowed to give narcotics in the field. There either had to be a physician there, like witnessing it, or a physician there to write a script for that patient. We all know that doesn't happen. So what we want, this law actually helps move that into what we actually do as practice. But there's also other gaps because in between the time the law was put in place about narcotic use, and in the pre-hospital setting, and today, states have filled in gaps. So there's multiple different places out there. So what we would like to do is with this advisory is that work with NEMSAC, all the EMS offices to actually build a document along with the DEA saying, this is what you need to do. Here are your contacts in your state, a very succinct, preferably a one-page document. Here's the website you need to go to. Here's what you need to know. Here are the tools that you need to actually make sure that you are compliant with the new law. And that is it for our committee at this time.
Thank you, Mr. Arkins. Any questions from the committee members for Mr. Arkins? Hearing none, thank you for the subcommittee reports from our 6 standing subcommittees. We do have an ad hoc subcommittee as well as part of NEMSAC, and that is the Motor Vehicle Crash Subcommittee. That is chaired by Dr. Gestring. Dr. Gestring, can you join us and give us an update on your committee's work, subcommittee's work?
Thank you, Brendan. Everybody's looking at my advisory here. Is that correct? Are you guys seeing that?
Yes, it's correct.
Larry asked if we could at least project the title. So our ad hoc subcommittee is working on an advisory entitled Development of a Comprehensive National Ambulance Crash Data Collection Platform to better understand current crashes and guide future preventative strategies. This has been in the works for a little while, but I think really has some direction now. I think it's really moving forward. It's currently in draft form. I expect it will be advanced, or at least a proposal will be made at the next meeting to advance it to interim status. The advisory has been crafted. Its direction has now been pretty much agreed to. Definitions are clarified, and now we're in the process of aligning strategic goals with recommendations. The main goals of this advisory are, number one, to better understand the full scope of the ambulance crash problem nationally. Number two, to develop infrastructure for better and more complete national data collection related to ambulance crashes. And number three, to inform preventative actions and perhaps design modifications and improvements based on what this information platform will provide in terms of new information. So we're moving forward, hope to hear more. The one thing I did pick up from GAM's presentation today, I think one area that we neglected to include, which we will add, is better education for EMS providers. The number of injuries related to unrestrained EMS clinicians is unacceptable. I think that needs to be part of our advisory. So we will be adding an educational component to our advisory as well. With a stress on the information that was shared earlier today. Thank you, sir. That's my report.
Thank you, Dr. Gestring. Any questions for Dr. Gestring in the work of his ad hoc committee? Okay. Hearing none, we're now at the point in the agenda where we talk about new advisory proposals. It's with great excitement that we look for new advisories and new work for the council to take on. As a reminder to any of the chairs making proposals today, the subcommittees must appropriately answer the following questions before the council can give the subcommittees the blessings to move forward into the research phase. 3 essential questions. Who's the audience? Is it USDOT? Is it the Secretary? Is it FICEMS? Number 2, what is the end goal of the advisory and the recommendations? What actions are you asking to target and to take? And is it within their statutory authority to take those actions? And number 3, does the federal guidance already exist on the topic? And if so, is there a gap in that federal guidance that is provided for EMS that needs to be addressed? And will that advisory assist in closing the gap? So it's really important that for anything that's proposed, we can answer those 3 questions cogently before that can be voted on and moved into the research phase of the process. To schedule and create the agenda for the meeting, Clary, Gam, and I asked each of the subcommittee chairs if there were any new topics that were to be proposed for the council. We had only one, and that was from Carol Jorgensen in the Professional Safety Subcommittee. Carol, can you speak? I know you spoke a little bit about it a few minutes ago, but if you can speak a little more about where you are with this and what the process is at this point.
For the one that we are proposing to transfer?
Right.
Yes. So that was the helicopter EMS landing zone best practices. Our subcommittee did have lengthy discussions about it, and once we all felt comfortable that it was really not an issue of the landing zone best practices, those were handled usually locally with the flight services that were serving those areas. We were comfortable with the trainings that were happening there, but we did have further conversations about maybe the utilization or inappropriate utilization or the overutilization of HEMS transports. So with that discussion that we were having, that was when we decided that it may fit within a different subcommittee better. And that was when we were proposing to possibly change the title to a Sustainable Practices for Appropriate HEMS Utilization for Emergency Medical Transport. But that would be up to the Subcommittee of Sustainability and Efficiency if they wanted to take that on, if it was an advisory that they felt like warranted research. So we would like to propose that they take that on and decide if they want to move forward with it.
Great, thank you. And I think we have to give you, Paul, some opportunity to think about this with your subcommittee. So we will revisit this tomorrow for an actual motion if that's going to move forward.
Great.
So thank you, Carol. Thank you, Paul, as well. We're at this period now for a break. We will be in break until 15:20. So we will stand in recess at this point. Thank you. I'd like to welcome everyone back from our scheduled break. From time to time, NEMSAC hosts information sessions from EMS community stakeholders. These sessions are also often a result of advisories from NEMSAC. Today we have a familiar face for the council and a very recognizable name to speak to NEMSAC about Prehospital Blood Transfusion Initiative. The chair recognizes Dr. John Krohmer. Dr. Krohmer, welcome back, and you have the floor.
Mr. Chairman, thank you so much for the opportunity to join you this afternoon and to share what we think is some very critical information. Just confirming, is the slide showing?
It is.
Perfect. All right. It is fun to listen to your discussions. There were a lot of things that were extremely enjoyable about participating in NEMSAC activities, one of which was certainly deciding where you're going to go for dinner in the evening. So I hope you all enjoy your dinner this evening. Thank you so much for the opportunity to share some information with you and for the time that you have allocated. We have several experts that are going to be participating in the discussion this afternoon, and as we go along, you will realize how expert they really are in their areas. I do note, and I'm well aware, that we have a hard stop at 16:20 for the public comment period. So everybody has committed to staying within the timeline that they have been allotted. We're going to talk this afternoon about a number of factors having to do with pre-hospital administration of blood transfusions, the importance of which is really demonstrated by this slide from an article which was published just a couple of months ago, reflecting that for every minute delay in pre-hospital resuscitation, we're seeing an increase in 2% in the odds of a 30-day mortality. So this is one of the components that we need to address. As was discussed earlier, 40% of the patients are alive when EMS arrives on the scene. Not that many survive. So this is one of the aspects that we can take advantage of to help improve that mortality rate. I'm going to turn things over initially to Mr. Bill Skillman, who is Vice President for Velico Medical, one of the initial supporters of this coalition activity, just to sort of lay the framework before we get started on some of the scientific evidence. Bill? Bill, please make sure you're off mute.
There we go. Thank you, John, and thank you to the Council for the opportunity to present the work of our coalition. But every year in the United States, thousands of people die unnecessarily from bleeding. In fact, it's the #1 cause of preventable death in trauma victims, with nearly half of these patients dying in the pre-hospital setting. But as we've learned, as programs have rolled out across the United States, there is also likely an equal number of medically associated bleeding patients from things like postpartum hemorrhage and abdominal bleeds who are also affected. But for the availability of a blood product at the point of care, we could save lives. And in fact, so our vision here, where we're headed, blood products available to every appropriate bleeding patient. But equally as important is to make sure that EMS is appropriately compensated for the field transfusion, the cost of the blood, and the cost to deliver that service. So our goals at a high level are to address both government and commercial payers, to reimburse for pre-hospital transfusions, and also to work with the appropriate organizations across the country to ensure that scope of practice is applied appropriately. In fact, we'd like to see that down at a paramedic being able to initiate a transfusion, not limited just to doctors and nurses. We're focused on 4 pillars of activity. Obviously, the first is reimbursement. We've already talked about scope of practice. We're working with BARDA to address also strategic preparedness, as I would say BARDA and others. And then there'll be an arm that's dedicated to education and outreach to all those in the field and EMS, you at the federal level, and others with an interest. But our goal here, I just want to back up for a second, John. The goal is to build a big tent. There have been many initiatives in the past to try to move things forward. Our idea is that we bring together blood collectors, trade associations, medical groups, all under one umbrella, align, and go forward together as one unified voice. So we'll take this action to Congress. We'll drive a call of action to CMS, but equally important to raise the awareness of the importance of blood on emergency vehicles within the general population as well. Next slide, John. We've formed a steering committee with known champions of pre-hospital transfusion over the years, including Dr. John Holcomb, Eric Bank, and associated with the Harris County EMS in Texas, the American Association for Advancement of Blood and Biotherapies. We've engaged John Krohmer as well. I want to point out just briefly that John has been engaged by Velico as an SME to help us learn how to better serve the EMS market, and also to support our activities here on this coalition. We've got Mary Homer from BARDA, and missing from today's presentation, Randy Schaefer, who was instrumental at STRAC in getting things going in Texas as it relates to field transfusion and helping sites across the U.S. get going. And then 2 of us from Velico, Karen Flanagan and myself. And just for the record, we're in this, we are developing a product, a point of care, dry plasma product for transfusion that's appropriate for use on all emergency vehicles. So John, with that, I'll turn it over back to John Holcomb.
Thank you, Bill. And we will be circling back toward the end of the discussion to talk a little bit more about the coalition's activities. Dr. Holcomb.
Thanks, John. So I'm going to go through some of the data that supports our thesis. Next slide, John. I always like starting with a little overview, where we've been and where we're going to go. Next. I spent, some of you all know this, I spent a lot of time in the Army, and military history is really important here. Back in World War II, blood products were the pre-hospital resuscitation fluid, including lyophilized plasma and whole blood. Not just 1 or 2 units, but over several millions of units of blood were given pre-hospital by medics on the battlefield. So as with many things in medicine, this is not a new idea. Next slide. Early in Iraq and Afghanistan, we discovered that giving less crystalloid and giving more balanced blood products was associated with improved outcome of survival. These are in-hospital data right now, 252 massive transfusions in 1 year in Baghdad. And really what we saw is we decreased mortality and decreased the coagulopathy that patients had by giving less crystalloid and more blood. Next slide. Damage control resuscitation components are really pretty simple, right? They've now been around for over a decade, but stop the bleeding, don't pop the clot, don't give crystalloid, give blood products in a balanced fashion or whole blood, use plasma as the primary resuscitation fluid, don't wait and give platelets late, in fact, give them early. Remember about hypothermia acidosis. Now this paper was published in 2007, so you could add hypocalcemia to that today. And then use all hemostatic adjuncts. And you go back to number 1 there, stop bleeding. Next slide. Move forward a couple years to 2014, and Tactical Combat Casualty Care, a group that you guys are all very familiar with, concluded that whole blood, based upon lots of intervening data between that 2007 effort, whole blood should be the number 1 resuscitation fluid, followed in order by balanced resuscitation with plasma, red cells, and platelets, plasma and red cells, and then many other blood products. And at the very end, some of the clear fluids. And then update to this in 2018, those clear fluids are removed, and only blood products are recommended by TC3 for patients in hemorrhagic shock. Next slide. Now, there are literally hundreds of other papers that deal with this issue, both single center, multi-center, retrospective, prospective, and some randomized, both military and civilian. And a lot of work by a lot of people, not just in the United States, but around the world, has really brought us, revolutionized how we do resuscitation for trauma patients in the hospital and the pre-hospital environment. Next slide. Jeremy Cannon published a NICE guideline in 2017 and really just kind of put the flag in the sand and said that damage control resuscitation, as I described it previously, is the standard of care. And you should do balanced resuscitation to resuscitate trauma patients. Next slide. Now moving pre-hospital, which of course is the most important area. This is data from Afghanistan published by Stacy Shackelford in JAMA in 2017. And you can see from the Kaplan-Meier there, huge differences in survival, massive differences in survival, both early and late, if you gave blood products pre-hospital to patients within 15 to 30 minutes of injury. Very few things will have this difference in survival that we do in medicine. Now, this is an observational study in the combat zone. Next slide. Then Jason Sperry followed up with what I think, and I say this every time, was one of the most important trauma papers published in the last 20 years, if not more. In the New England Journal of Medicine, prospective randomized level 1 data, multi-center, pre-hospital. And again, on the Kaplan-Meier shows a big difference in 30-day survival, 10% absolute difference, 30% relative difference. And the difference occurred at 3 hours, including head injuries. So giving blood products pre-hospital compared to crystalloid dramatically improved outcome. Multi-center, prospective randomized. Next slide. People always ask about crystalloid. The crystalloid bags have been around forever. They're really cheap. You can store them at room temperature. They're ubiquitous. They're a lot cheaper than all blood products. And you kind of think back, why do we give crystalloid? And I've given buckets, trainloads of crystalloid in my career, and I didn't really ever think about it until the last, say, 15 or 20 years. Next slide. Brian Cotton published a paper in 2006 and went through every step on comparing more crystalloid to less crystalloid in all the papers. There's not a single paper that I can find that giving more crystalloid is better than giving less. The bottom line is every 250 to 500 cc's of crystalloid you give your patients pre-hospital or in the hospital, the worse off they do. Next slide. This is documented in this paper that came out just this year in Shock, replicating what I just said. Every 500 milliliters of pre-hospital crystalloid increased ARDS and coagulopathy and anemia, and really was detrimental to the patient. That's every 500 cc's. Next slide. Now, using the NMSAC data, the 2019 data set, and we are updating this right now with support from your group, the Zain Hashmi, who's a young surgeon who works both in the ED and pre-hospital at the University of Alabama. We looked at who's using whole blood and who's using blood products, just looking at who has these available. And back then, with the 2019 data set, 24% of trauma centers in the United States were using whole blood. Very little was documented in the data set. Now, this is going to be increased as we update this paper this year with a more recent data set. Next slide. And then we published through the Thor group and with our folks that in the blood bank and emergency medicine from around the country, and you guys know many of these folks, how to do a pre-hospital blood program. Eric Bank, who's going to speak in just a minute, was instrumental in setting this up. And this is now spread across the country, but there's lots of things that go into setting up a pre-hospital blood program. I'd recommend this paper that goes through credentialing, paperwork, storage, and indications for transfusion. Next slide. One of the things that people always talk about is, what about women of childbearing age? I was taught in medical school not to give O positive or Rh positive blood to Rh negative women. And in fact, when you dive down in the data, and I'll just summarize this slide and the next one, that is true if you have it available, but the death rate from hemorrhagic shock is so massive, and the complications from alloimmunization, which is what we were talking about with the Rh factor, is really pretty small and probably overstated in most of the textbooks that I learned from. So many centers around the country now are transfusing Rh positive blood to Rh negative women because of the risk-benefit ratio. Next slide. And in fact, a young female trauma surgeon did a national survey using Facebook, social media, which was really interesting, and looked at 2 million people. And the females in that group the group of females of childbearing age responded likely or neutral when asked if they would receive the risk of alloimmunization. The national survey suggests that most females would accept life-saving transfusion, even with the risk of future harm. So it was interesting that female trauma surgeon went out and asked women what they wanted rather than a bunch of guys deciding what they would get. Next slide. Going back to the supply of pre-hospital resuscitation, there's a lot of need out there. You guys know this. The data certainly supports it, but there are a lot of reasons, and John and the rest of the group will go through this about why there's this mismatch between patients who need blood products and the numbers that are available for them and the patients who actually receive blood products. Zain really he's a trauma surgeon, but he's an epidemiologist at heart, has put together these data in a really nice fashion. Next slide. And then closing with this joint position statement that comes from American College of Surgeons, the American College of Emergency Physicians, and the National Association of EMS Physicians. Number one, stop all compressible hemorrhage and give patients blood products. Kind of a summary statement for the data that we've just gone over, replicating the Berry paper that John started off this conference with. Next slide. Thank you very much.
Thank you, Dr. Holcomb. I want to make an observation. If some of you, as you were looking at those articles that Dr. Holcomb was discussing, realized that his name was on a great majority of those papers. That's not because Dr. Holcomb talks about only the papers that he's involved with, but the fact that he's involved with this stuff from such an integral aspect. He really is one of the gurus, not only in damage control resuscitation and care of injured military when he was in the service, but he really is the guru helping to support a lot of activities that are going on in developing pre-hospital blood transfusion programs. So, John, we're extremely excited that you're participating in this coalition. Thank you.
Yeah, John, thanks. Either that or I'm just the oldest guy hanging around for a long time, one of the two, right?
Well, you and me both, but it's a reflection of how knowledgeable he is in these issues. There's been a lot of attention paid to the development of blood transfusion programs in EMS agencies over the last couple of years, and it has picked up enormously. I think one of the things that we need to be aware of, and that candidly surprised me, is that there have been EMS agency blood transfusion programs going on for a number of years, going back to 2013, 2014, 15, and 16. We're going to now turn to Eric Bank, who has been involved in the development, implementation, and running a program in his agency since 2016. And we'll spend a little bit of time talking about the pre-hospital implications of getting a program going and running it effectively. Eric?
Thanks, Dr. Krohmer, and thank you to the council for letting us talk today. So just real quick, there are some products on here that I do mention because we've been doing this for a little bit. We don't endorse receiving financial compensation, but they're in there, so I figured I'd throw that slide in. So kind of give you the boots on the ground overview. Harris County ESD 48 Fire Department, we couldn't pick a smaller name. We're the west suburb of the city of Houston. As you can see, a fairly mid-sized city for unincorporated. There's not tumbleweeds rolling through. 6 ambulances and EMS supervisor. 2022 world champion Houston Astros. But while we're in an urban center, we're 29 miles away or 45 minutes away with no traffic. If you've ever been to Houston, that doesn't exist, from the closest level 1 trauma center. And this kind of played a key role as we kind of went through and developed this process. Next slide. So what we do know as EMS clinicians, EMS practitioners, EMS administrators is we can't control what's in the EMS space, right? We can't control the uncontrollable. The event brought us here. We got to go through and mitigate the situation, take care of patients, bring calm to the scene, mitigate the circumstances, but we can't control how we got there, but we control things once we get there. This is a picture from an active shooter event in Santa Fe from a few years back. And this will be a little more relevant here as we get to the end and kind of talk about how these products play a role. Next slide. So if we go back to 1994, I think you probably can guess the city there with the famous bell. I was a pretty young paramedic responding to an assault. It's a male patient, about 30 years old, semi-conscious. He's cool, ashen, diaphoretic. He's obviously in hemorrhagic shock. His heart rate's 130. His blood pressure is 60 systolic. He's got a very large laceration to the upper abdomen. It's not bleeding. He's got defense wounds. Both brachial arteries are cut. Now remember, it's 1994, so tourniquet's a bad word. And we'd have to make one if we had to do that. So how do we treat this patient? And again, it's 1994, right? It's quite a few years ago, almost 30 years ago. Next slide. And there is the key pieces to trauma care in the 1990s. My light goes off in my office. Applied diesel fuel, lots and lots of fluffy Curlex, gallons of normal saline, and a 14-gauge IV catheter. So let's jump forward 10 years from that call to, again, Harris County ESD 48. Sort of a similar patient, shot instead of stabbed. Again, pretty obviously in hemorrhagic shock. Pretty ugly vital signs. He's got a single GSW to the left buttocks that transversed out definitely took out his femoral artery very high. And he really has no other injuries. He was running away from a house he just robbed when the homeowner shot him. Next slide. So how did we treat this patient in 2014? Diesel fuel, Curlex, very large amounts of normal saline, and a 14-gauge IV catheter. With one other caveat that thanks to the military and thanks to some of the technology that's changed, Doc, if you hit the button there, I think the next thing will pop up. And we had tourniquets and combat gauze. But that was to stop the bleeding, which we were having a very difficult time because this was a very high femoral injury. But it's 20 years later, and this is the same care that we're giving. Think about how many changes there have been to ACLS in 20 years. Go and roll to the next slide. So this is when I sit down and go, does this make any sense? Does it make any sense at all that 20 years later we're still doing the same thing? And we started the battle for pre-hospital blood, and it, there's the 2016 Zero Preventable Trauma Deaths paper that's there, the military folks. We already had blood in the air medical world. Our famous Thor hat there, and a lecture that Dr. Holcomb and I were given when our friend Andy Fisher started making some memes. Let's roll over to the next slide. So how did we do this, right? Did we just, pick up the phone and 2 days later we had blood on an ambulance? No. So first I had to have a discussion with the medical director. And of course, Texas is a delegated practice state, so we don't have a scope issue. We had to work through the gaps with the local blood bank, right? So the local blood bank is usually dealing with hospitals. They don't know what we do. They don't know what an ambulance is. They know what one is when it shows up, but they don't know that they can put blood on it. Thankfully, Dr. Beth Hartwell was there, and she really helped us through this process. And then the part that'll drive everybody nuts is the logistics and maintenance, right? So what's the usage levels? What are the guidelines? How do you replace it? Who's going to pay for it? How do you hand off a patient the ED or for a flight? How do you bill for it? Can you bill for it? And then be able to convince your local hospitals and trauma centers to be able to do this. It took just over a year from concept to inception to get this off the ground. And every time I think we were close, we'd have to go back and make some adjustments. And we've obviously fine-tuned the process since then. And this was actually in late 2015, going into 2016, starting with component therapy and not whole blood just yet. Next slide. So blood products for ground EMS, obviously, as Dr. Holcomb pointed out, used in the military ops as far back as World War II, actually probably earlier than that. Very commonly used in theater in Iraq and Afghanistan. The transition to HEMS or Lifelight, obviously this is an old slide. They started in 2011, giving blood products in the helicopter. We made our request in early 2015, and we deployed our first units in February of 2016 and transitioned to low titer oil whole blood in August of 2017. Not a hard date to remember, both because of the blood products and the fact that Hurricane Harvey came through like 3 days later. Next slide. So there's three main functional areas of a pre-hospital blood program. There's the medicine part, right, is the right thing for the patient, which we know it is. What is the scope of practice in your region or your state? The logistics of daily operations, and the logistics of managing the blood supply. 1 and 2 are easy. 3 is much more difficult, and we've made some strides there, but that's really where we have some of the biggest issues. Next slide. So the medical issues, like we pointed out, nationally, you have a scope issue. It changes from state to state. There's a paramedic education process. We have to see what blood products are available and be flexible. How are we going to deliver it to patients? What about rural agencies who are not close to anything? Improving blood bank and EMS relationships. Female patients, as Dr. Holcomb alluded to, and I'll talk about here in just a second. Transfusion reactions, something we need to be prepared for. Blood supply. The blood supply is precious, right? So availability, cost, flexibility, and we have to make sure we enhance the life cycle of the blood and be sure that we're not wasting any product. And of course, there's the costs. Next slide. So what about medically based hemorrhagic shock? Karen actually put this slide together, so it's the Irish or the English spelling of hemorrhagic, by the way. So symptomatic bleeding, regardless of cause, needs to be treated. So when we first created this, we said, boy, we really ought to create a medical guideline, because we would look really dumb, if we end up with a medicine patient and we don't have a guideline for blood. And what ended up happening is we're about 3 to 1. We do 3 medicine patients to every trauma patient. Our demographics are a little bit different than San Antonio and New Orleans. I think they're probably at probably 50-50 or maybe 60-40. And that's mostly GI bleeds, OB complications, and bleeding. And that brought in the question of the female patients and using the positive low titer whole blood. Next slide. So in September of 2017, we had done multiple transfusions of component therapy, but in September of 2017, we believe we did the first whole blood transfusion in the U.S. I say we believe we did because I can't be 100% sure, but I'm pretty sure. And it was a mid-30s female patient who was hemodynamically unstable in gross hemorrhagic shock 2 weeks postpartum. And our next 3 deliveries after that were medicine patients. So again, that's where we've kind of learned the process, and you can see how much her vital signs changed with the 1 unit of warm low titer whole blood. Next slide. So obviously trauma care today has changed quite a bit. There are quite a bit of tools in the toolbox. The TXA has gained popularity in the country, the 2-gram bolus, blood products, working our way through the trauma triad to make sure we're using warm products. We have IO access, we have hemostatics. But again, the one true life-changing event or life-changing device that we have our access to is going to be blood products. Next slide. So in summary, you guys are all in EMS. You know that we have standards for STEMI, standards for stroke. There is no standard for trauma. The golden hour really doesn't exist. It was a good concept initially, but we know it's probably a golden half hour, especially somebody with a severe truncal injury. The Stop the Bleed programs are growing and doing great. We need to make sure that EMS clinicians understand the trauma triad and now the trauma diamond. And we have to be the voice of change. We have to drive this through. We have to be flexible. Low titer whole blood's always available, but other blood products are. You have to learn the process and seek assistance from others. I get phone calls and emails just about each and every day. Fight like you train, especially for daily operations. And real quick, because I'm pretty short on time, or actually a little over. The event that you saw was an active shooter event where a law enforcement officer took a shotgun injury to his arm that was pretty severe. He's pretty severely bleeding. They got a tourniquet on. He was still in hemorrhagic shock. When he was brought out of that building and he was brought over to one of the helicopters, he actually received a whole blood transfusion on the way to the hospital. So this plays roles in multiple aspects of what we do, not just daily, but also in MCI operations. And I apologize for being about a minute over here, but I'll turn it back over to Dr. Krohmer.
Perfect, Eric. You're spot on. Thank you so much for that information. Obviously, we're talking about EMS blood transfusion programs. This can't happen without the involvement or the ability to access the blood components. And we have been very fortunate as this steering committee has developed to have the participation of Susan and some of her colleagues. We're reaching out to all of the organizations that are involved in blood collection, blood distribution, in addition to AABB, the American Blood Centers, and the American Red Cross. But AABB has been very proactive in helping to support the concept and the implementation of pre-hospital transfusion programs. So Susan, fill us in a little bit about what's been going on, and it's tied in with some of the hurdles that we still have to overcome.
Thank you, Dr. Krohmer, and thank you to the council for having me here today. So we have, AABB, our mission is to improve lives by making transfusion medicine and biotherapy safe, available, and effective worldwide. Our members include a lot of the blood collectors, and we work very closely with America's Blood Centers as well. And so we had a lot of our members came to us to try to figure out what to do with this. In 2020, we worked with the EMS community to come up with some ideas. We had lots of meetings with various stakeholders, including NAEMS, AAA, a lot of the physicians, EMS physicians, and a lot of other stakeholders. And we started to explore basically different ways for payer coverage and reimbursement. We did a one-pager, which is what you can see here. We sent that to CMS. We also worked on draft language to kind of take two approaches. One, going through the national payers, which is the Center for Medicaid and Medicare Services, to try to enact change through the innovation centers, or otherwise known as CMMI. And two, through a congressional effort by trying to get some legislative language to change the policies that are in existence that governs how the ambulance fee schedule, or how ambulances are paid for these additional products. So the great thing is we kind of worked really hard, and unfortunately CMMI did not move forward on the request that we sent in 2020. And in terms of the bill language, it was also a difficult year. There was a change in administration. There was also a change in terms of priorities by Congress, and we can see some of those effects to this day. So there wasn't any movement on that bill language. However, this year, AABB and our colleagues worked really hard to try to get pre-hospital blood transfusion language at least added on some of the emergency preparedness legislation, more specifically the pandemic and all hazards preparedness reauthorization language, which we were successful in getting some language in there on the Senate side. However, as many of you know, Congress is on recess, and they have 11 days when they get back in September to try to pass all of their appropriations bills and reauthorization bills. So it's unclear at this point what will happen to this must-pass legislation, and if on the House side that they will take up the same language that we were able to get done on the Senate side. But we are working hard to make sure with our House champions to make sure that that gets added on when they come back. Next slide, please. So as I mentioned, the proposed service delivery model that we sent in, that to CMMI was not selected because of the organizational strategy change. We received a very kind note back, and we're still thinking about other ways and actually working with them to think about other ways where perhaps we could have some sort of demonstration project. But many of you know what happened with ET3. If that's not going to work, then we're still going to try to reach out for legislative language. Although right now Congress is not moving very quickly on a lot of it, but we're hopeful because we have some champions that may pick up the language to add to some of the other appropriations bills, as I had discussed earlier. In the EMS community, as you've heard, there's a lot going on. This group that we're part of, the Prehospital Blood Initiative Coalition, is working really hard to do outcomes research. And you've heard some of the research that, from Dr. Holcomb, but there's more research to come that will help our efforts both on the congressional front as well as on the payer front. And at AABB, within my organization, we are working with the Thor working group, and as well as we are always looking for other people to sit on our committee as we develop standards to help not only with those that already have programs that are running, but for future programs that want to have. Next slide. I think that's all I have on updates, but we are looking for more people to help efforts too.
Thank you. I feel obligated to put on my former bureaucratic hat for just a second and make sure that everybody understands that, we were talking about efforts to educate other departments in the executive branch. We were talking about efforts to educate the legislative branch. That was not, that was purely for your information sharing so that you are aware of those activities. We are not in any way, shape, or form asking any of the feds who participate, are sitting in the audience, or NEMSAC to become involved in that. We just felt that it was extremely important that you be aware of the activities that are happening in the community if somebody were to ask you about them. Before we move on, Dr. Gestring, did you have a question?
Thank you, John. I definitely do, but I was going to wait till the end of the presentation. I just wanted to get at the beginning of the line.
Perfect. Thank you. One of the individuals that has been extremely critical in the initial activities of the steering committee leading up to the development of this coalition is Randy Schaefer, who is a retired military critical care, emergency, flight nurse, whatever else, who has also been very instrumental in the development of military and now civilian blood programs. Is not able to join us today. She's actually on a plane after having spent the last 2 days in North Carolina working with folks who are doing blood programs there in their EMS agencies. She and Eric have been the principals in developing a survey and starting to gather information about the status of blood programs in the EMS community. We have a little information here that Eric will share with you, and with the understanding that this is one of the activities is hoping to continue and expand so that we can get a better picture of what's going on in the community. Eric.
Thanks, Dr. Krohmer, and I'll echo that. Randy has definitely taken this on and has hard charged at this, and we've been working on a Google sheet that we kind of work on back and forth, and trying to actually capture the number of agencies who are actually doing this. So if you'd have turned back the clock probably 3 to 5 years ago, I could tell you the 7 agencies that were doing this. And each year, and actually now each day of the week, this tips towards standard of care, and there are a lot of programs in process right now. And currently our best guesstimate, working through Google searches and talking to folks around the country and requesting information, is there are now 112 ground ambulance agencies across the United States. You can see kind of the breakdown there. Just to go through miscellaneous is some states are limited scope. So the Office of the Medical Director or the EMS fellows are out in a vehicle with blood products. There's some law enforcement programs, both state-based, federal-based, that carry blood products. And there are there's a military base in California that actually has a civilian EMS program that actually carries blood on the base. And so that kind of falls in that miscellaneous category. And you can see kind of the breakdown of products. Majority of low titer O positive whole blood it's really the easiest product to carry. But again, there are some restrictions in some of the states. So as we work through this, one thing I'll definitely ask the committee to please help us with is, one, if you know of someone in your community that is doing this, please have them contact us. Our contact information, I'm sure, will be here at the end of the process. I even tell folks, even if I know you, I've talked to you, I know you're doing it, please just let us know so we can double check. As we continue to grow this, we really truly don't have a centralized reporting process to figure out how this is progressing. And that's going to be important as we work on scope issues and work through the federal system for reimbursement, to make sure we have a pulse on how this is going and getting the data back, again, to show, our effectiveness. Like, there probably isn't a person here on this call who can't get a STEMI picture and turn around in 24 hours, but we're still struggling to get trauma data. So this is a pretty important process. And again, we're kind of striving through this. And when Randy and I probably first started putting this together, we were at about 2.5 months ago, we were probably at 86 to 88 programs. And so you can see that the growth is actually there. 3 states now have coalitions working on this. Florida has a group working on this. South Carolina and Colorado. Texas has the STRAT coalition that's very strong in this process. They have their Whole Blood Academy. They have a whole process through that group with Dr. Jenkins through the STRAT program. So again, we're starting to see this increase across the country, and both Randy and I get phone calls and emails daily of folks looking for guidance or letting us know what's going on. So please share this with your colleagues, and please have them report back to us so we can kind of keep this up to date. Doc, I'm not sure if she had another slide in here, so let's.
Oh, that's it. Thank you, Eric. We're going to circle back just for a couple of minutes and again put the coalition in concept and in perspective. We have talked about all of these issues as being critical to the development and implementation of pre-hospital blood transfusion activities. As we lead to the expansion of the coalition, it is with the goal of being all-inclusive. And I say that in terms of all-inclusive in the type of blood products. It may be whole blood, it may involve packed cells, it may involve plasma, it may involve more than one or all of the above. But we are agnostic to the blood product being utilized by the EMS agency. We also want it to be all-inclusive in the context of anybody and everybody who is interested in participating, interested in learning, and interested in developing programs. The clinical considerations have already been addressed. We have historically tended to focus on trauma patients. It's critical in trauma patients, as we all know, but as Eric alluded to, there are a number of medical conditions that also scream for the administration of pre-hospital blood programs. We've talked about the scope of practice, which is an issue that needs to be addressed, acknowledging that the scope of practice is defined by every state. Having said that, we think that there are some ways that we can work collectively to help facilitate not only incorporation into schools, but education of EMS clinicians and education of the community, all with the goal of making sure that the right patient gets the right product in the right situation. Eric has touched very nicely on the logistics and financial considerations. We're not going to spend a lot of time talking about them now, other than reinforcing the fact that they're all issues that need to be addressed by the coalition. And the funding considerations, both Bill and Eric have alluded to. Susan mentioned some of the activities that have been tried. There's a lot that still needs to be done. There are a number of mechanisms and avenues to approach to try and get these addressed. This, the group of folks that Bill talked about earlier started meeting a number of months ago and having these discussions to start to identify the issues, start to identify the potential players and the like. We are now at a point where we will be starting the activities of the overall pre-hospital blood transfusion initiative coalition. Initial emails have been sent out to a number of players, including major EMS national organizations. We have shared and will be sharing more information with the federal agencies that are involved in EMS. Bill alluded to the fact that we're focusing on these 4 pillars to try and address all of the activities: reimbursement, scope of practice, strategic preparedness, and outreach and education. As I mentioned, we've reached out to some organizations. We'll be starting these pillar activities hopefully within the next month or so. We will be starting a general coalition meeting and hopefully expanding from that. So this is our way of telling you, spread the word when you hear about it and encourage folks that are interested. The goal really is to develop a very collaborative process involving all of the players who may be involved. We'll be addressing, obviously, structure and process issues as the organization becomes more active and more fully involved. But it really is, we're trying to use this as the impetus to bring the community together and figure out how we can address this issue. I want to thank everybody who has participated. Anybody on the steering group, Susan, John, Eric, or Bill, anything to add before we go into questions? Okay, and since Dr. Gestring threw the gauntlet down first, please go ahead, sir.
Thank you, John. I wanted to take this opportunity to congratulate your team, you specifically, but your team in general, for bringing an extremely important issue in front of a group that probably otherwise would not have necessarily heard about that. Being a proud native of probably the last state in the country to allow helicopters to give blood, maybe the second to last, I fully understand the difficulties, the nonsense we had to go through in order to do what other states have been doing for years on their helicopter services. But we've absolutely seen an improvement, in all the things you guys talked about with the ability now to give blood in helicopters in New York State. This is an extremely important initiative, and as we talk about our future directions for NEMSAC, as the token trauma surgeon in the room, I'm absolutely going to suggest that we look at how we can help. I mean, the medicine behind what you're talking about is clear. The logistics are less clear, but NEMSAC, the National EMS Advisory Council, exists to help with some of those logistics. And I think if we can make some definitive statements to the EMS community in support of what you're talking about, I think that would provide a lot of help to to organizations as they look to do this. I think the helicopter EMS population, the crews, maybe it's a little bit easier for scope of practice, but there's an opportunity here for us to produce, I think, a very important advisory. And when we look at the tasks that we've been charged with, we just finished hearing about the National Roadway Safety Strategy, and the significant element of that is post-crash care. Well, pre-hospital blood transfusion would absolutely fit into that wheelhouse. So I think we do have the ability to provide significant assistance in this effort, and I would like to be one of the voices that say we should, as a group, do that.
Thank you, Mark. And obviously one of the national organizations that'll be integrally involved in this is the Committee on Trauma. Thank you for your comments about the steering committee. I appreciate them, but this is not my initiative, folks. I'm honored to be able to help coordinate some of the EMS activities and to facilitate this discussion, but the other people that talk today are the ones that are really making all of this happen. Thank you. Mike, please.
First off, thank you all for a stellar and exciting presentation. And this is probably already on your radar screen, but it popped into my head, so I had to mention it. I visited Israel a few years back, and it seems like the Begin David Adam in Israel, their national EMS system, also runs the blood bank for the country, so that they're integrally connected. And I responded with them to an explosion, and while the responders were in, taking care and doing triage for patients, two Winnebagos showed up about a mile from the site and parked in neighborhoods, and people from the neighborhood came out and donated blood. So they got close to 100 units of blood donated, kind of using the situation and the explosion as inspiration for local donations, and it was all really well coordinated. So just a benchmarking opportunity for you.
Thank you. I appreciate that. I've already put in a request to do a field trip to Israel, but we'll see how that goes. Mr. Chair, I may have stepped on toes here. I didn't mean to start calling on folks if...
I have no issue with that, Dr. Krohmer.
Okay. I'm sorry. Old habits die. Dr. Wasu Ansa, nice to see you.
Dr. Krohmer, always great to see you. So thanks. I think this is a wonderful coalition that's happening. I would be amiss, of course, if I didn't mention the little people and how they're involved in this coalition. As we know that, trauma is the leading cause of death in pediatric patients, and that includes hemorrhagic shock. We also know that we don't have as much data as we do for pre-hospital blood transfusions for pediatric patients as we do for adults. There was a recent article in JAMA Pediatrics by Morgan et al. That did show a reduction in 24-hour mortality rates for children. But again, and I think a previously older study in 2008, but we don't have nearly as much in the way of background. So wanted to find out what's being done in that regard, and what expertise are you looking for when it comes to pediatric patients, hemorrhagic shock, and pre-hospital transfusion for those little ones.
Perfect. Thank you. Yes, it is on the radar. We have had discussions about that. We will be involving those. Yeah, he's waving now. I was going to say, Dr. Holcomb is one of the very strong advocates to make sure that this is included in these activities. John?
Yeah, John, thanks. I couldn't agree with you more. Many sites that start giving blood pre-hospital usually exclude pediatric patients. After they get over the initial phase, which is largely emotional, then almost every site rapidly drops their age limit down to 2 or 1 or 0. And as you said, one of the main causes of death in young kids is hemorrhagic shock. The data that are out there are not as robust as in the adult data. But I think most of us that take care of these kids would treat pediatric patients with blood products who are in hemorrhagic shock. And the studies are coming. They're going through the NIH and BARDA pathways right now.
So if I could jump in there real quick, we are doing this. We started out initially. We had a 5-year cutoff, which we had a consult the medical director. Now that's down to 6 months. And while it's not a regular occurrence, we have done 4. And actually, those have all been whole blood. So, and then Dr. Peter Antevi, who's driving this in the Florida region, as you know, is a pediatric EM doc, and that population is near and dear to his heart, and their recommendation as well is pediatric patients. I think most of the guidelines now are the cutoff is typically 2 to 3, and it's not a true cutoff; it's just a medical direction request.
Brandon, thank you for sharing that reference in the chat. Do you want to comment any further?
No, I just saw it posted by Dr. Antevi recently, and as he always tends to share things through Dropbox, I did the honorable thing to steal it and repost it.
We'll make sure he is well aware of that. Thank you so much. Other questions, comments, or suggestions from anybody? Again, we are extremely appreciative of the opportunity to chat with you and the time you allotted to us. That was very generous on the part of the council. You will be hearing things from your organizations in the EMS media and other outlets in the very near future as we prepare to call the first meeting of the coalition and some of the pillar working groups together. Mr. Chair, thank you so much.
Thank you, Dr. Krohmer, for that excellent presentation and the entire team that you brought with you today. Very important topic for sure, and I think the council will spend some time thinking about ways that we can help. And certainly, if there's ways that we can work with you, more than happy to have those discussions. Very, very worthwhile project for sure.
Thank you so much.
Okay, we have public comment in 5 minutes, but we do have a roundtable discussion planning for internal discussions. So I'd like to move to that point in the program now. And when we do get to 1620, we will pause for public comment. So because we have a fair amount of new members on the council that just started, I'm interested in your feedback on how your subcommittees are going, level of participation, activity, and whatnot, and that's what's been happening there. So I'd love to hear from both the subcommittee chairs as well as the participants in the committee and how you feel your subcommittees are running at this point. Do you have good participation? Is everyone contributing as we're moving forward? Because we certainly have a lot on our plate right now. Does anyone want to start? Dr. Gestring.
Thank you, sir. I would just want to congratulate the new members, at least on my committee, my ad hoc subcommittee. A real breath of fresh air, a new perspective, expertise that we didn't have before. I think we had found our direction prior to the new folks coming on board, but they absolutely helped us crystallize, a direction and a message. And I think, just like the tide, I think that influx of new energy each couple of years is super important and bring new expertise and new vision. I think it's great.
Thank you, Dr. Gestring. Any other subcommittee chairs want to give input? Any participants of the committees want to give input? Mr. Brennan.
Given it's the summer season, it's a little more difficult. We had a meeting mid-July, July 20th or so. So knowing that's really difficult to have full participation during that, I think that prior to that, we had a good representation, and we're moving forward. We just need tonight for someone to happily accept the vice, or I should say the co-chair position.
I feel very confident that we will leave tomorrow with all the vice chair positions filled. Ms. Jorgensen.
I would just like to comment that I have been so pleased with the participation of the new members. Their expertise has been so valuable to what we're discussing. They bring so many different things to it, so many different perspectives, and they have not hesitated in speaking up, and I very much appreciate that.
Thank you. Mr. Tagman.
So as one of the new members, I feel like I've been drinking from a 5-inch fire hose. And I feel a little bit like a kindergartner who entered a grad school situation. So one of the things I'm curious about is there's like a level of expertise in understanding the process and all the other things that have been done that the chairs and people who've been around for a while seem to have grokked. And I'm trying to catch up on all that kind of stuff. But if any of you have any coaching on how to wrap your brain around all the other things that have been done, so you don't continually toss out things and say, well, there's these 17 things that have already done that suggestion, and so that I can do that kind of stuff early, that would be helpful.
Yeah, I think that's great. I think that's a great comment. There is certainly within the EMS.gov, there is a list of all the advisories that have been promulgated by the council. And I think that that's helpful in understanding what's out there today and what we can build on from that today. But I think, I think the biggest challenge for me a few years ago was understanding all the letters. What every letter means, what every organization can contribute, and the fact that we have the ability to bring in subject matter experts to help shape and guide the advisories that we're going to build. So there's a lot there for sure. And I want to come back to this after public comment and talk a little more about this on how we can be more efficient as a team. Because we do have I will tell you, based on the last council, we have a tremendous amount of advisories on the table right now. There's a lot of work that's happening, and we want to make sure we can delineate that labor correctly. I think we are in public comment at this point, so I will pause for public comment. And Clary, do we have any public comment, received any public comment?
Yes, sir, we have. Public comment number 1, the International Association of Firefighters, IAFF, the International Association of Fire Chiefs, IAFC, National Association of Emergency Medical Technicians, NAEMT, and the American Ambulance Association, AAA, appreciate the time and consideration of your well-intentioned advisory, and this is directed to David Pfeiffer and his committee on Subcommittee on Adaptation and Innovation. However, our organizations oppose this advisory and request it to be tabled indefinitely. Services across the country are struggling through a severe workforce shortage of EMS personnel, and collectively our organizations are fighting to secure sufficient funding and federal funding to hire, train, and adequately compensate our workforce. Adding an additional level of provider will only detract us from our primary mission of emergency response and interfacility transportation. Currently, there's a path forward for those wishing to advance their careers to become a physician, physician assistant, nurse practitioner, nurse, respiratory therapist, to which we lose EMS clinicians annually. Additionally, the skill set of the graduate level paramedic will mimic or be seen as a scope creep by nurse practitioners and physician assistants, and it's most likely be strong opposed by both. Considering CMS and CMMI's recent decision to end the ET3 pilot program, is unlikely CMS would see benefit of a graduate paramedic and allow for reimbursement like a nurse practitioner or physician assistant. We politely ask you to withdraw this advisory and join us in the effort to secure essential funding to recruit and retain EMS personnel to help us overcome the current workforce shortage and to ensure an affordable, accessible, and equitable pathway for entry-level practitioners. Again, that was from AAA, IAFC, IAFF, and NAEMT. We received that prior to the meeting via email. Today, we've received several more comments. Also addressed, all these comments are addressed to the same subcommittee and regarding the same advisory. Dear NEMSAC, I'm a paramedic, an EMS physician, and a state EMS official. Regarding the proposal designation of graduate prepared paramedics as federally recognized practitioners, not only should NEMSAC support the proposal, but I heartily embrace it as one of the first true attempts to actually addressing the root cause of the massive amounts of attrition we have seen on ground EMS services in the last 5 to 10 years. Far from taking paramedics away from the service, this will provide a path for EMS personnel to advance to a true professional practice rather than a vocation. Rather than distracting from important issues, this proposal goes to the heart of the EMS crisis, addresses the cause of the disease rather than trying to make it appear that symptoms are not there. I discussed this proposal with my group of fire EMS administrators yesterday, and they unanimously concluded that this would be inspiring people to enter and stay in the EMS profession rather than pull them away from it. It may not make people want to be firefighters, but it definitely will go a long way to making them want to be paramedics. As for a personal example, most of my young life, I wanted to be a paramedic, but I decided to become a physician instead when I realized that I would reach a ceiling of my paramedic vocation in my early 20s and would spend the rest of my working life at that level. Had the career path for an advanced level practitioner been available at the paramedic at the time, things would have been done differently. I implore NEMSAC not to let this opportunity pass. Sincerely, Walt Lubbers, MD. Another comment. I'm writing in support of the draft proposal for the advisory at hand. I have worked in the Prehospital for the last 17 years, beginning as a volunteer firefighter, then an ED paramedic, and progressed in my career to firefighter, paramedic, rising to the rank of captain to single role paramedic, and now serving as a division chief over education in my agency. My service experiences a high turnover rate, and in exit interviews, the common refrain is the lack of opportunity to advance beyond paramedic. I would expect this to be a common refrain nationally, that skilled, capable paramedics are leaving the field due to the lack of opportunity to advance. Internally, we have put in place several specialty teams and education opportunities for our staff, but the chance to have a graduate level provider to provide high quality care to patients that may not require transport to the emergency department or have long-term health problems that cannot get appropriate care, home care on hand would be excellent growth opportunity for EMS as a whole. The current climate of workforce shortage is multifaceted, and the proposal is not an overnight solution, but we desperately need some long-range thinking and planning to update how pre-hospital care is performed in the future of our industry. We in the field and in the department leadership need to make sure our services are attractive to people in the field. However, we need opportunities for our providers to continue to grow. The graduate prepared paramedic practitioner gives us this opportunity. Additionally, many of the funding options that are open by having graduate prepared paramedic practitioners will see the industry better funded for the skills already performed daily. The paramedics we train who leave us to seek expanded skill sets are seeking opportunities that they would absolutely perform in the field if these types of roles existed. Please support this measure and open more opportunities for our future of our industry. And this comes from Jonathan Osterman, paramedic. And here's the last public comment. I'm writing to support the draft advisory for the designation of graduate paramedics as federally recognized practitioners. I've worked as an EMS professional for 15 years with an experience in many different service delivery models. I have experience as a single role paramedic, emergency department paramedic, and a career firefighter. Like many of my coworkers, I'm currently pursuing undergraduate education with the goal of completing a graduate program to obtain licensure as a physician assistant to progress my career and clinical abilities. This advisory would help create a path not only to retain my EMS professionals, many EMS professionals such as myself, but would also better ensure the future generations of pre-hospital clinicians to have a path to clinical advancement. Current workforce shortages are affecting almost every industry in healthcare. While this advisory does not solve the problems the EMS profession faces, it provides a rational solution to the majority of issues pushing paramedics out of the field while providing alternative solutions to many of the reimbursement challenges facing EMS agencies today. Respectfully submitted, Ryan Stull, National Registry Paramedic. That is all the public comment that I have at this point. I'm going to go back to, I got another one that just came in. Okay, this is submitted unanimously, but it is not it's in response to, I believe, professional safety. As a daughter who lost her father, a firefighter, in a line of duty death on 12/6/2022 in a struck-by incident, I am passionate about the Traffic Incident Management Program and believe that the advisory into developing the TIMS to be a nationally accepted and implemented guideline for safety. I urge you to give all EMS practitioners the safest patient care scenes as possible. I'm directly involved in my local area and I have become an EMT and safety officer since my father's death. I'm sorry if I butchered the last name, but Kurt Kielhofer, Safety First motto will live on forever. And just confirming, I believe I had one other, yes. This is submitted anonymously. Why is that word difficult today? Hello, are there any updates regarding air ambulances and the recalled airbags? We'll direct that at Director of Office of EMS.
Can you repeat that just one more time?
The question was, are there any updates regarding the recalled airbags and regarding air ambulances? Two different questions, but it's asking for updates.
So I don't have any specific updates. I'm not sure. It might help. I'm not sure what airbag recall the person is.
Unfortunately, they didn't go into a lot of detail about the question, so that's all I have. To whomever submitted that public comment, we'll do some research, find out. If you'll email me directly at clary.mole@dot.gov, I'll be able to get you a response on the public comment, on your public comment on our website after the meeting.
Clary, is there any more public comment in your inbox?
I believe that's the last one.
Thank you. At this point, we will close the public comment period. I do want to thank everyone that sent the public comments in. I think it's incredibly important to our friends at IAFF, IAFC, AAA, and NEMT, and the folks that took the time to send information in today. You know, your comments are extremely helpful in guiding the council's activities and helping us to make decisions about where these advisories go over time. Mr. Pfeiffer, it appears that you have elicited some interest in your advisory, in your subcommittee's advisory, and I would ask, certainly because there was a fair amount of activity and comments today, that maybe tomorrow during your subcommittee meeting you can, you know, ponder those comments and maybe even respond to them. I think that would be healthy. Any other questions or comments before we move back into roundtable discussion? All right, so back on the roundtable side, I think, you know, and I think opining on what Mr. Brennan said, as I think, over the summer, it has been a bit of a challenge to get everybody together and make sure that we're working on these advisories. And as opposed to the last council, where we had two committees that we each served on, we now have three. So I think time management and resource management is really important on these subcommittees, and making sure that, the chairs and the vice chairs, or soon-to-be vice chairs by tomorrow, have the ability to delineate work product across the entire working mass, so that it's not the same folks that are doing all that work. And I'd ask that each of the subcommittee chairs really try and be diligent with dispersing that work evenly across your subcommittees. Just from this morning, I think we all had some conversations about other advisories that we want to take up. That would be value add, and we're actually in a position now where we're trying to figure out how we can fit them into subcommittees that don't already have 3 or 4 advisories that they're working on. So it's really important that we're all, up at the plate, and we're all swinging as hard as we can to get these things promulgated. I know from my own experience when I joined the council, the first 2 or 3 or 4 months are really a learning curve. And understanding, what our role is and how we do things, how we make recommendations, who they go to, is half of the Pythagorean theorem that we have to be able to master. And we're lucky enough to have, Clary, who is extremely helpful with this, and we have Gam, who is extremely knowledgeable in this, to be able to help guide us. So, from my own perspective, continue the great work everybody's doing. Tom and I are here to support and to make sure that we can participate as well. We have pretty much consistently made it to every single meeting that's happened since we've been elected into our positions. And we want to continue to do that, to be able to support all of you. And for those of you subcommittee chairs who can't make a meeting, or even a vice chair who can't, we're happy to run your meeting for you as long as we get a little information beforehand to keep progress moving. We think that's so important. I would love for the council, this sitting of the council, to have the highest amount of value-added advisories promulgated and pushed to NHTSA than has ever happened within the organization, because we have such a huge pool of talent in this room, on this council. I am really in awe and inspired by all of you and what you've done over the course of your careers. And I know Tom and I, we talk about this all the time. What an amazing team we have in this group right now. So we want to continue to do that. With that, I'll open it up to any other roundtable discussion. Any other discussions that anyone would like to bring forward or have? Tom, comments? I can't be the only one talking.
We were good at it, though. Yeah, right. So I'd actually like to echo your sentiments and stuff. Having sat through all the different committee meetings, and I get what you're saying, drinking from the fire hose, both figurative and literally having done that.
Hopefully not the foam hose.
No, I'm not one of the people on TV for that deal. But it is a lot to intake. But it's just taking small bites of it and stuff. Tabby and I have text conversations quite a bit about what's going on with stuff, and it's a learning curve. And honestly, Brendan and I are still learning. Our first few meetings were virtual. So we didn't have the ability to sit down after dinner and talk to people and figure those things out. So we're still learning a lot of how this goes. But having sat in the committee meetings, it is great to hear everybody talking and stuff. We literally spent a half hour talking the other day about what an ambulance was. But it was actually a really good conversation. It was trying to define what it was for this particular advisory. So there was a lot of people bringing a lot of different ideas to it. So please don't be afraid to speak up. Brendan and I did that. I'm not sure, maybe that was the best idea sometimes, but yeah, speak up, bring your ideas to it. If you hear, talk to the people around you, see what are people talking about. See what's showing up in all the different news media things. See what's going on across the world. What are the things that maybe that's happening across the world that we can bring to our divisions and stuff, and that we can learn from people and maybe help move EMS a little bit further ahead here.
Thank you. Any other comments from the council? Dr. Gestring.
I know this isn't maybe the correct venue to talk about new advisories, but since I won't be present tomorrow when you're doing that, I was inspired by what I just heard about the pre-hospital blood transfusion. And I think that there is definitely value that we could bring to the logistics side of this. And I just want the group to consider that. I'd certainly be happy to be involved in that with what the group decides. It's certainly an uphill lift. I mean, I think the logistics are not are not easy, but there's real value in doing this. And I think based on what everybody said, this is the right group to get that ball rolling. Simple stuff like, does NEMSAC, include pre-hospital blood transfusions, for instance, and how does it include it? Simple, data collection stuff that would help move this argument forward and the process forward. So, as you guys talk about this, I think probably tomorrow you're going to be doing a little bit more discussion about this, but feel free to sign me up for some of that if you decide to move forward.
Thank you, Dr. Gestring. And I think we are going to probably have some conversations about this tomorrow. From my perspective, on the blood program, I tried to start a blood program not too long ago, and the two things that damaged our attempts to do that was A, reimbursement for blood, which is very expensive, as you all know, and B, the ability to work with blood banks in a state of national blood shortage. So those are real concerns, and those are things I think that maybe the council from a logistics perspective can have some input into. But during our strategic discussions tomorrow, I think it would be worth the council spending a little time talking about it. So thank you, Dr. Gestring. Any other comments? I keep missing the hands up on the screen, so I apologize. All right, well, we're at that time of the day where we're just about done. I think we've really gotten a lot done today. Just even the subcommittee meetings this morning, I think there was a tremendous amount of work that happened. I think it's been a very productive meeting. I love the fact that we have subject matter experts coming in and speaking with us. I know there's a whole slate of folks that we've or are reaching out to come in and do more and help guide us in different things that we've asked and are interested in. So there's much more coming on that. Dr. Gestring, I see your hand up, so I'll catch you before I go any further.
Just before you wrap things up, I just wanted to congratulate David and his committee for poking a stick into an extremely important beehive. This is more public comment than I've seen collectively since I've been on this group, and I'm going in my beginning of my third year. So that means you're talking about something important. So congratulations. I think you guys are on the right track.
Agreed. So the one thing I would ask is, we've got another full day tomorrow with three subcommittee meetings that are going to be meeting tomorrow. We also have another public comment period tomorrow as well. So I would ask everyone just to kind of ponder the work that's happened today over the course of the night tonight. I know many of us will be getting together. Not that we'll be talking about it at dinner, but please just think about what's happened today, the different topics that have been brought up, the public comment and whatnot, and that will help shape and guide how tomorrow goes. We do have a fair amount of business to get through tomorrow, including the advancement of several advisories into different levels of the process. So I think that's going to be really important. Hopefully everyone will get a good night's sleep tonight. It's been a very productive and informative day. Thank you to all the members of the public who have joined us for our meeting today. Thank you to all the subcommittee chairs for the hard work that you've taken on and the respective advisories that you've been working on. Thank you to all the council representatives who flew here to Washington to make sure you could be present for this, and for those who are participating remotely. Also, thank you to all of the folks, again, that sent public comment in. I would love to see 25 minutes of public comment every single meeting. I think it's so valuable to hear from the EMS community and others who can help shape and guide the work that we do. We will reconvene tomorrow at 1 p.m. With federal updates starting at 12 noon. That will be rolling presentations. If there's no other business that's here today, I would open the floor for a motion to recess. Can you unmute and...
So moved.
Do I have a second?
Second.
All in favor, unmute and say aye.
Aye.
Any opposed? Unmute and say nay. Any abstentions? Unmute and abstain. The motion passes. We stand in recess. Thank you.